All right, welcome back, everyone. Thank you for returning on time, and welcome back to our 2,000 plus webcast viewers. It's wonderful to have you all with us today. Here to share with us the latest results of the best practices identified during their 2013 audit from the Division of Analysis, Policy and Strategy, Lorelei Piantadosi.
I'm much shorter than the previous presenter, so bear with me a moment here while I adjust the podium. So thank you for joining us this morning. As Stacy said, I'll be discussing the 2013 best practices and common findings from the program audits conducted last year. Just a brief overview of the presentation today. I'll touch briefly on the soon-to-be released 2013 best practices and common conditions memo. We will then review the 6 program areas that were audited in 2013, and then we'll walk through the best practices and common conditions for each program area, along with example causes for these conditions. Please note that for this presentation, I'll use the terms condition and finding interchangeably. As I mentioned, the 2013 Best Practices and Common Conditions memo will be released shortly. There have been 3 previous Best Practices and Common Findings memos released, as Jerry had noted earlier, that related to the program audits conducted in 2011 and 2012. CMS encourages sponsors to utilize the information contained in these memos to enhance their compliance with CMS regulations and policies. As we walk through the common conditions for the 2013 audits, I will note the percentage of sponsors audited in 2013 that received that condition in that program area, and also note if the condition was cited in previous memos. So there were 6 program audit areas audited in 2013. Part D, Formulary and Benefit Administration, or FA. Part D, Coverage Determinations, Appeals and Grievances, or CDAG. Part C, Organization Determinations, Appeals and Grievances, or ODAG. Compliance Program Effectiveness. Special Needs Plans, Model of Care. And Part C and D, Outbound Enrollment Verification Calls, or OEV. So we'll start with the Part D Formulary Administration area. So one best practice noted was a very robust drug utilization review program that flagged claims for pharmacist review if there were 4 or more prescribers or 4 or more medications in the beneficiary profile from the same therapeutic class. Another best practice was with oral corticosteroid claims. One sponsor conducted claims look back for a history of immunosuppressant drugs, and if there were no immunosuppressant claims in the beneficiary history, the claim automatically paid under Part D as a drug. Another formulary best practice not noted on the slide is 100% claims review look back, rejected claims look back, to identify and correct all formulary and transition errors. And this process is followed up by a periodic rejected claims review to ensure that no new errors are occurring. So we'll move into the common conditions or common findings for formulary administration. Unfortunately, all 5 of these formulary common conditions found in 2013 have been listed in each of the 3 prior common conditions and best practices memos. The first one's 61% of the sponsors audited in 2013 failed to follow their CMS-approved formulary by applying unapproved quantity limits. A common cause resulting from this condition was utilization of maximum daily dose limits that were more restrictive than the CMS approved quantity limit and the FDA maximum daily doses. 39% of sponsors audited in 2013 applied unapproved utilization management practices. So this is other than quantity limits. One common cause noted for this condition failure was claims being rejected for formulary drugs that were dispensed in the smallest commercially available package size when the day supply submitted was based on the prescribed dose, but it exceeded the plan's day supply benefit. 43% of audited sponsors failed to properly administer the CMS Part D transition policy. Causes for this condition include adjudication of claims with utilization management edits not allowed during Part D transition. So this would be edits other than Part B versus D determinations or safety edits other than the FDA maximum recommended daily dose or refill too soon edits. 39% of audited sponsors improperly effectuated a prior authorization or exception request. For example, when the authorization expiration date was entered into the adjudication system, the approval was not through the end of the plan year or through the was different than the duration of therapy that was noted in the CMS approved criteria. A third of the audited sponsors failed to provide a transition supply for continuing beneficiaries that were eligible for transition. This is sometimes caused by faulty look-back logic for prior claims history or for incorrect identification of drugs with a cross-year negative formulary change. So moving on to best practices noted with CDAG, or Part D coverage determinations, appeals, and grievances. The first best practice was noted in a sponsor that made payment for direct member reimbursement on a daily basis. The next best practice was daily review of Part D versus Part B rejections from the previous day, and if a coverage determination process had not already been started, then that process was started the following day. So they would start researching claims logs and call history and begin to conduct outreach to pharmacy and providers. Another best practice was utilizing a 180-day claims lookback for claims history on formulary medications that had a CMS-approved prior authorization for new starts only. The two most common conditions noted in 2013 CDAG audits have been noted in each of the three previous best practice and common findings memos. 89% of the sponsors audited in CDAG in 2013 had the condition noted where denial letters did not include an adequate rationale or contained incorrect information related to the denial. This is often caused by lack of adequate policies, procedures, processes, training, and/or oversight to ensure that denial notification letters contain language that is understandable to both the beneficiary and the prescriber, and to ensure that the letters are accurate and complete. The second most common CDAG condition was noted in 78% of the 2013 audited sponsors and was related to the inability to document that the sponsor conducted sufficient outreach to the prescriber or the beneficiary in order to obtain additional information necessary to make an appropriate clinical decision. An example cause of this condition is lack of a formal outreach policy or the policy not being followed, or lack of internal controls to ensure that sufficient documentation is obtained from the prescriber. The third and fourth common conditions in CDAG have been noted in two of the three previous best practice and common findings memo. The fifth common condition listed here has been noted in all three prior memos. These three conditions were noted in almost 60% of the sponsors audited in CDAG in 2013. Auditors found coverage determinations or redeterminations being misclassified as a grievance and/or a customer service inquiry. An example cause of this condition is lack of effective controls to monitor the processing, classifying, and resolution of beneficiary inquiries to ensure that Part D requirements are being followed by employees, such as grievance counselors or customer service representatives. There's also untimely notification for standard coverage determinations or exceptions requests. This may be caused by inadequate coverage on weekends or holidays to ensure that cases are worked within the required CMS timeframes, or by the sponsor's policy not aligning with CMS policy when cases are tolled for receipt of information requested from providers. And the fifth condition was inappropriate denials when processing a coverage determination, noted when there was a lack of internal controls to ensure compliance with internal policies or lack of controls to verify clinical accuracy with medical necessity denials. The next program area that we'll discuss is Part C, Organization Determinations, Appeals, and Grievances, or ODAG. The first best practice noted in this area was a sponsor assigning a healthcare manager to assist beneficiaries that needed assistance in understanding the authorization and reconsideration process. Another was a sponsor recording 100% of their customer service representative or CSR calls to allow for a more comprehensive review and to improve classification issues. One sponsor automatically expedited reconsideration requests for skilled nursing facility admissions. The most common ODAG condition noted in 75% of audited sponsors in 2013 has been noted in one prior best practice and common finding memo and is related to sponsors failing to make timely payment decisions after receiving an organization determination request. An example cause of this condition is the sponsor failing to have proper oversight of its delegated entity that's responsible for timely claims payment. Failure of timely notification with standard organization determination requests was the second most common condition noted in 2013 and was found in 58% of the sponsors audited. This has been noted in 2 of the 3 prior best practice and common findings memos. And this condition is often caused by lack of effective processes and controls to ensure that organization determination requests are adjudicated in a timely manner. The 3 remaining ODAG common conditions have also been noted in 2 of the 3 prior best practice and common findings memos. And all 3 of these were noted in at least 50% of the sponsors audited in 2013. Denial letters not including adequate rationale or containing incorrect information specific to the denial is sometimes caused by the sponsor's EOB lacking the capability to include descriptive language that fully explains the reasons for denial. Denial notices for non-contracted provider payment requests lack specific denial reasons and failed to describe the appeals process. And lastly, sponsors failed to demonstrate sufficient outreach to obtain additional information necessary to make a clinical decision. This condition may be caused by lack of effective processes and internal controls to ensure the sponsor obtains additional clinical information from providers prior to the sponsor making a prior to making a coverage decision. So moving on to compliance program effectiveness. There were several best practices noted in this program area in 2013. The first being that employee security access badges had the contact information for the compliance and fraud, waste, and abuse programs on the back of the badge. Another sponsor automated the process of checking the HHS Office of Inspector General and General Services Administration excluded parties list system. One sponsor has a process for HPMS memo distribution by functional areas with a follow-up process for the operational owners who are responsible for implementation of the new guidance. Another sponsor provided detailed training on roles and responsibilities and CMS requirements for their governing body members. Another best practice was an online monitoring tool to track and manage corrective action plans. And an internal Medicare fraud, waste, and abuse, or FWA, prevention program was developed to engage employees and delegated entities in FWA detection and prevention. The two most common conditions for sponsors audited in compliance in 2013 have been noted in one prior best practice and common findings memo. 2/3 of the sponsors audited in 2013 failed to review the OIG and GSA exclusion list for applicable personnel and/or first-tier downstream and related entities, or FDRs, prior to hiring or contracting the personnel, and they also failed to review the list on a monthly basis thereafter. A common cause of this condition is lack of sufficient resources being utilized for reviewing the exclusion list in accordance with CMS requirements. 36% of the sponsors audited last year were not able to provide documentation that their compliance program effectiveness was audited annually and that the results were shared with the governing body. For example, one cause noted was that a sponsor had hired an external auditor to perform a compliance program audit. However, the audit failed to review the elements of an effective compliance program as required by Chapters 9 and 21. CMS found that 29% of sponsors audited in 2013 failed to provide direct fraud, waste, and abuse training, or FWA training materials, to their FDRs. This condition has been noted in two prior best practice and common findings memos. And an example cause is failure to have a process in place to ensure that all FDRs are identified by the compliance program, by the compliance department, to receive FWA training both upon contracting and annually thereafter. The fourth most common condition for compliance in 2013 was cited when the sponsor could not provide evidence that general compliance information was communicated to FDRs. This condition has not been noted in prior best practice and common findings memo and was found in a quarter of the sponsors audited in 2013. The fifth common condition for compliance has been noted in two prior best practice and common findings memos and was noted in 25% of the sponsors audited in 2013. This condition is noted when the sponsor fails to distribute the standards of conduct and policies and procedures to employees that support the sponsor's Medicare business, according to CMS requirements. An example cause of this condition is lack of internal controls or a process to ensure that FDRs receive the sponsor's standard of care and policies and procedures, or that the FDRs had comparable products. So we'll move on to special needs plans model of care next. One best practice was a model of care set standard that performed the initial health risk assessment within 30 days of enrollment. And another sponsor had an embedded nurse program where the nurse was included on the interdisciplinary care team to aid in the individualized care plan, or ICP, implementation where they could easily assist in member assessment and care coordination. 2013 was the first year that SNP MOC program audits were conducted, so these common findings have not been listed in prior memos. 3/4 of the SNP MOC sponsors audited in 2013 have these first two common conditions. The first is failing to administer the initial HRA within 90 days of enrollment in the SNP. One cause noted was inadequate staffing to manage all elements of the sponsor's model of care. And the second was failing to administer the annual reassessment within 12 months of the initial assessment. The third and fourth conditions noted here were identified in more than half of the SNP sponsors audited in 2013. The third condition is failure to provide evidence that there was an ICP for the beneficiary. An example cause here was that care coordinators were not following the model of care for clinical services. The fourth condition was noted when the ICP failed to address issues identified in the HRA. An example cause was that case management staff did not have the requisite knowledge or expertise to identify or prioritize health risks. And another example is that the delegated entity responsible for the ICP didn't receive the health risk assessment, and so the HRA couldn't be developed, or excuse me, the ICP could not be developed based on the needs identified in the HRA. The fifth condition noted was found in 42% of the SNP audits in 2013, when there was lack of evidence of ICP implementation in the care management or case management notes. A cause noted for this condition was lack of adequate staffing to manage the required functions such as documentation and existing staff carrying a very heavy caseload. And the last program area that we'll discuss today is Part C and D Outbound Enrollment Verification, or OEV. One best practice noted was that all OEV calls were recorded, and this included calls that were incomplete or cut off, and also recordings of messages that were left when the beneficiary was not available. And then also repeat OEV calls to beneficiaries being made on separate days and at different times of the day. There was also a call center program that required the CSRs to correctly and completely go through the call strip before the user screen could advance to the next page. And another sponsor sent OEV letters to every beneficiary after the first OEV call attempt, regardless of the outcome of the call. And the last OEV best practice was noted where rapid disenrollment and cancellations were communicated to both the enrollment and the sales and marketing departments for lessons learned purposes. The most common condition in 2013 related to OEV was noted in 2/3 of the sponsors audited and has been in each of the prior best practice and common findings memos. Sponsors were found to not comply with CMS regulations for OEV calls and were providing inaccurate information to beneficiaries. An example cause of failure was failure to follow the CMS-approved 2013 OEV call script during the OEV call. The second common condition was found in 1/3 of sponsors audited in OEV in 2013 and has been noted in 2 of the prior best practice and common findings memos. Sponsors were mailing incomplete and/or inaccurate OEV verification letters. This may be caused by lack of adequate controls to ensure that the information in the letter was accurate, such as the cancellation date or use of a permanent address when a separate mailing address has been provided. The third and fourth conditions on this slide have been noted in each of the prior best practice memos. 26% of the 2013 audited sponsors did not have evidence that at least 3 OEV calls had been made. Example cause here is that CSRs are not following their training. And 22% of the audited sponsors last year could not provide proof that the OEV letter had been sent. This may be caused by a lapse in following a standardized process. 11% of 2013 audited sponsors did not meet the time requirement for mailing OEV verification letters. This may be caused by ineffective training of OEV representatives and a lack of oversight of delegated entities. So in conclusion, there were some excellent best practices noted in the 29 program audits that were conducted in 2013, but there were also many lessons learned noted. As Jerry noted earlier, CMS recommends that sponsors take the common conditions memo and best practice memos and read through it. I know it's dense information, and also utilize prior memos that have been released, but add these common conditions to your risk assessment so that your internal audit processes can identify and correct areas of non-compliance in your program. And we have the Part C and D audit mailbox up there if you have questions or feedback on any of the memos or any recommendations to how we can better the program. You can use that mailbox at any time. And it's time for questions. Does anybody have any questions for us? Yes, ma'am. Yeah.
My question is for Part C, specifically from the provider's side. Can you please, talk more about the reconsideration request for SNF admissions automatically expedited as a best practice for the ODAG?
I don't have the details of that best practice up here. As we went through the audit reports, we pulled out best practices that had been notified by had been noted by the audit teams, but for the specifics of that program, I would have to go back and look at that specific sponsor.
Okay. I'm just very curious as to, the wording, redetermination requests. For SNF admissions. And I guess since I'm just curious as it's about length of stay, or is it about denials of, and then we're on to the reconsideration request. So I'm thinking it's that second level. So.
Okay. Well, and we haven't issued the memo yet, so we can always provide more clarification on that best practice in the actual memo.
Thank you.
You're welcome.
Hi, Chris Bowers, United Healthcare, and you may have the same answer. You may provide more information in the memo, but I just was wondering if you could provide any more detail around common finding number 4 for CDAG, so sponsors not providing not notifying the beneficiary or prescriber as appropriate within the timeframes, and specifically you mentioned sponsors having policies that didn't align with CMS when told for supporting statement. Is there a specific example or any more details you can provide around that?
We might be able to provide more in the memo. Sorry, okay. I have pared down talking points.
No problem.
Hi there. Thank you for the terrific information. Just a quick clarification. I think it was previously mentioned that the audit redesign process began in 2010. And I think you had mentioned that the SNP model of care was implemented in 2013. Is that correct?
Yes.
Okay, so is this implemented in pieces, and the SNP MOC was implemented just last year?
Yes.
Got it. Thank you.
Yeah, on a limited number of sponsors. Okay. So it wasn't, there were 29 sponsors audited overall, but SNP MOC was just a portion of that.
Got it. Thank you.
You're welcome.
Good afternoon, Krista Fagan from Performer X. I guess my question is kind of twofold. One, the common findings are really helpful, but would CMS consider releasing an FAQ document for the questions that are actually emailed in? I guess that's question one, and the reason behind that is because as a PBM, we're actually we're involved in a lot more of the mock audits, and I guess with your typical health plan. So we run into situations where we have a clarification from CMS about one item, and this mock auditor may have a completely different answer. And since we develop our program around the responses we receive, that would just be really helpful.
I think we're working towards getting frequently asked questions posted, and as soon as we do, we'll make sure that that's broadcasted out so that all sponsors have access to it.
Thank you. One other question, and this is probably something just to take back. In terms of the 2014 protocols, one of the fields for the CDAG universe is the date and time that oral notification was received. We did receive clarification that even if we made the good faith attempt, which for us is actually 3 phone calls, but we did not connect with anybody, we should still enter NA in the universe. But we've already been through a few mock audits where they think otherwise. So
okay.
Maybe I'm not expecting an answer now, but if that's something you could consider.
Okay, we can provide, I'll make note of that, and we can hopefully
Thank you.
clarify in the protocols for next year. Any other questions? Okay, thank you very much.
All right. We are a little bit ahead of schedule? Yes, ahead of schedule. So we are going to go ahead and take a quick 8 minutes, no more, an 8-minute break. So you can get up and walk around, but please be back here at 11:15, and we will start promptly at 11:15. Thank you. Welcome back from your break. We are ready to get started once again. And welcome back to our webcast viewers. If you are just joining us today on the webcast, we have a very packed agenda today of many CMS subject matter experts and other experts that are with us today that we are delighted to have. And speaking of being delighted, we are delighted to have with us this morning a panel of experts that will provide us with an understanding of the 2014 program audit process. From the Division of Audit Operations, I would like to introduce Tawanda Holmes, along with Daryl Brookins, Doreen Galliano, Sheetal Pasrita, and Jessica Robinson.
Good morning, everyone. Can everyone hear me okay? Is the mic on? Can you hear me okay? Is that better? So good morning, everyone. So for today, we want to just dive a little bit deeper into the audit process from beginning to end. But before we get started, one of the things I always like to do when I attend conferences is take a quick poll of the room of all the sponsors that have had the privilege of being audited by our team. So we'll start with 2010, just a raise of hands. 2010, great. 2011, fabulous. 2012, fantastic. 2013, excellent. And 2014, brave, outstanding, great. So thank you so much. And also, if we have not reached you, and if you want to refer yourself, see one of us. We'll be glad to take that on. So I have this dynamic team of folks here. These are the audit leads as well as team leads, the absolute best team in CMS that I have the privilege to work with. And we're going to walk you through the audit process. So one of the things I want to mention is that we actually had a video to show you guys. But what happened, because of all of this dynamic talent, it took so long to edit that video. It's about 1 hour and 20 minutes. It should be 2 hours because that's how great we were. So we need a little bit more time to do some more edits to that video. So hopefully we will have it out within the next 30 days. So today, we will present a little bit more details around the audit process. And this will be at a level that I don't think we've presented before. Next slide, please. So specifically, we want to discuss or provide some insight to the discussions the audit team has with the sponsors leading up to the audit, during the audit, as well as after the audit. Also, each team member will discuss 2 cases from each audit area. Now, unfortunately, we had screenshots to actually give you all a visual, but we want to take some precaution and actually reach out to those particular sponsors just to make sure we have their permission to use those screenshots, because we don't want to be in a position that we're sharing proprietary information. Now, although the team did an excellent job scrubbing the data to make sure there's no personal information there about beneficiaries or HICCINs or the name of the sponsor, we just want to just double check with those sponsors to make sure it's okay. And if they are indeed okay with that, we will release the video, because some of that information in the video. So I just want to ask everyone to please put on their imaginary hat as the team walk through the cases, because you won't have the visual, but they will still provide you the data. So with that, I'll turn it over to my colleague, Doreen, and she'll walk through the audit conferences.
Good morning, everyone. My name is Doreen Galliano in the Division of Audit Operations, and I'm going to start by walking through the different conferences that we have as part of our audit process in 2014. The engagement letter follow-up call is the first call that we have with the sponsor after you have received the start notice, just announcing that you've been selected, and that typically will take place 2 days after you receive the start notice. We also will be talking about the entrance conference, the pre-exit conference, and the exit conference today. The engagement letter follow-up, what we do is, again, we talk about the letter, we get into the specifics about the dates and the times that we will be conducting the audit, as well as the various activities during the audit. That includes universe dates, when they're due, the audit start date, and each of the conference dates. We also talk about the staff that we need to be as part of the audit. Some of those staff include the CEO, the medical director, a board member, and any other necessary staff that are leads for each of the performance areas. We also talk about the universe request and answer questions that the sponsor may have about the template. Sometimes we get some questions, it's not clear, and some people just want to ask what goes in different columns on the universe template, so we're happy to answer those. And then, next slide, we talk about the self-disclosure template, and this is something that we ask the sponsor to fill out and submit to the audit lead prior to the beginning of the audit. We also talk about the EFT and HPMS. As you may be aware, the universes are uploaded into the EFT, but because they're so large, typically, we cannot put those in HPMS, but all the other documents around the audit would be uploaded into HPMS, so we have one system of record. We also walk through the different webinars and talk about the performance areas and what's expected. And it's important to note that we do perform during week 1 all of the performance areas concurrently, if possible. Some of the smaller sponsors sometimes, if they share staff, let's say for formulary and CDAG, we can definitely work with you. We can be flexible and schedule those on separate days. We also talk about FDRs and PBM. We try to find out what specific tasks your PBM does for you. So we're going into the audit understanding who does what. And then we go through logistical items and talk about what staff will be on site during week 2 during the compliance review. Then on the entrance conference, we obviously do introductions to make sure everyone's familiar with all the CMS auditors as well as the plan staff. We talk about the audit process, what we're going to be doing during week 1. We also discuss any issues that we may have seen thus far with your universe. We go through internal systems just to make sure that you're able to pull up specific screens that we'll be looking for. And we talk about how CMS really desires to be transparent as we can during the audit and identify whether or not a case passes or fails. Sometimes we do have to pen cases, and if we do, we get back to the sponsor as soon as possible, preferably after we review any additional documentation that people might submit. And then at the end of the entrance conference, we also allow the sponsor to make a presentation. Some sponsors like to orient CMS auditors to the operations and the organization, talk about the different staff that are going to be leading each performance area, and we allow them to make a presentation on the entrance conference. Moving on to the pre-exit conference, the purpose of this is to talk about the conditions that we saw during week 1 of the performance audit. We also provide the sponsors this year with a written list of all the conditions so that you can actually walk through those. We give it to you prior to the pre-exit so that you're able to reach out to your audit lead with any last-minute questions and talk through those. We also talk about the immediate corrective actions that we found during that first week of the performance audit and any best practices that we would like to note for that specific sponsor. Then during the exit conference, again, we might follow up on any issues from week 1. We also talk about the results from week 2, which is the compliance review. And again, we provide the sponsor with a written list of all the findings prior to the start of the exit conference. We also will talk about post-audit activities, and that would include when you can expect your draft report to be issued, as well as how you can contest any findings, should you decide to do that, and when you can expect your final report to be issued. Now we're going to move to specific audit areas, and I'm going to pass it over to Sheetal to talk about formulary administration.
Hi, my name is Sheetal Pasrija, and I'm going to be going over the formulary administration portion of our review. And the 2 audit areas we're going to go over today are formulary and transition. The website review and P&T committee reviews are conducted prior to the start of the on-site audit.
Sheetal has a nice, soft voice, so we're just going to give a little bit help.
Thanks, Tawanda.
Sure.
Before we start the case review, I'm going to go over some housekeeping items. The first item is we will be uploading samples 1 hour prior to the webinar each day. Next, we will identify and communicate any findings associated with cases that failed during the review. And each finding will be identified as either an observation, corrective action required, or immediate correction action required. This determination may be made after the on-site webinar review. As Doreen stated, any cases that are pending will be assigned a pass or fail status sometime during the on-site review. Lastly, we'll ask that you provide screenshots of any cases that have a pend or fail status. And now I'll go over the order in which we will be reviewing the cases. We will first verify the beneficiary information, such as the date of birth, HICN, and name of the beneficiary. We'll next we'll look to see when the beneficiary was eligible for coverage. Then we'll look at the drug quantity, day supply, and detailed rejection messaging for the rejected claim in question. And lastly, we'll also look at the beneficiary claim history to see if there was a paid claim for the drug. And now we'll begin our case review. So the first case is for a formulary administration sample for Niaspan ER 500 milligram. We'll first verify the member name, date of birth, and HICN. We'll then look at the member's eligibility details to see if this is a new or continuing beneficiary. And next, we'll look at the claims to look at our sample case in question. Again, this claim in question is for Niaspan ER 500 milligram tablets for a quantity of 60 and day supply of 30. The drug is on the sponsor's approved formulary with no quantity limit. The rejection states, plan limitations exceeded. The detailed rejection messaging to the pharmacy states, for the 1,000 milligram dose, use the 1,000 milligram tablet. So now we'll look to see if there were any paid claims for the Niaspan. It looks like the member did have a paid claim for a different dose of this medication. There is a paid claim for Niaspan 1,000 milligram for a quantity and day supply of 30. It looks like the member experienced an inappropriate rejection when attempting to fill the 500 milligram tablet. This claim did not follow the CMS approved formulary and therefore would result in the following new finding. Failing to properly administer the CMS approved formulary by applying unapproved quantity limits. And now on to the second case. The second case is a transition case and it's for Prestige. Again, we'll verify the member's name, date of birth, and HICN. We'll look at the member's eligibility details. It looks like this is a new member and it's eligible for a transition fill within the first 90 days of their transition period. This drug has step therapy requirements. And now we'll look at the claims to see if the member had a prior transition fill. The beneficiary drug profile shows that the beneficiary had not previously received a transition fill prior to the rejected claim. The rejection shows that this drug is rejecting for step therapy requirements. This claim rejected in error and should have paid as a transition fill since the member was within the first 90 days of the plan. This would result in the following new transition finding. Failing to provide a new beneficiary transition supply of a medication with the CMS approved step therapy requirement. This now concludes the FA portion of the review. Thank you.
Thanks, Sheetal. Okay, I'm going to take it over from here and just walk through a couple mock audit cases for CDAG. We're going to, I'll talk about what we look for in the sponsor's live system for CDM and a mock audit grievance case. So for CDAG webinar, CDM, It's very similar to what Sheetal described for formulary, so I'm not going to go through every single order because it's pretty much the same that we do for CDAG. So if we can go up to this one would be good. Samples, again, are just uploaded 1 hour prior to the webinar, and we will identify the different findings and conditions, whether it's observation car or ICAR. And then at the end of that day, we ask the sponsor to upload all supporting documentation for all failed cases so that we can review that. So I don't have a slide for this particular, as Tawanda described, mock audit CDM case, so I'm just going to describe it to you, and then I'll read the different conditions that we found as a result of this beneficiary case. The sponsor received a coverage determination request for Orencia injection on January 13th at 5:59 p.m. The coverage determination was an urgent request. However, the sponsor failed to recognize that it was urgent, and they did not expedite the decision. They did, however, make an outreach attempt to the physician on January 14th and tried to obtain additional information, however, did not reach the physician. The request was denied on January 14th at 3:02, and they did provide oral notice on 1/16 at 11:06 and written notice to the beneficiary on 1/16 as well. They used unapproved utilization management criteria, and the denial letter did not contain all the criteria, nor did it have the citation notes. So that's the case, and here are the findings that I, as a CDAG team lead, or any of our auditors would note for that particular case. So the conditions for this CDM case: sponsor did not appropriately notify the beneficiary or prescriber of its decision within 24 hours of receipt of the expedited coverage determination. Second condition that we would cite for this: sponsor did not appropriately auto-forward a coverage determination exceeding CMS required time frame to the IRE for review and disposition. Additional conditions that we would cite is that the denial letter did not include adequate rationale, and it contained incorrect information specific to the denial, which we all know that if the beneficiary or the prescriber does not have specific information, they don't know what they need to do next to get that drug approved for the beneficiary, it's much more difficult for them to file a correct appeal. Sponsor failed to properly administer its CMS approved formulary by applying unapproved utilization management practices. And lastly, the sponsor made an inappropriate denial when processing this coverage determination. So those would be the conditions that we would cite, and we would walk through those and make sure that the staff responsible at the plan for the CDM review fully understood what those findings were. Next, I'm going to talk about a grievance case. What we do again for grievances for this review is we look at the beneficiary's name, receipt, and date of the grievance, whether or not it was written or oral. If it's written, we look to see the actual request so that we can read it ourselves. If it was an oral or verbal request, then we ask to see the call notes that should be in the sponsor system. We look to see if the sponsor processed the grievance correctly. We look to see the different steps that they took, and very importantly, we look to see if there should be a related coverage determination. Oftentimes, grievance staff lose sight of a related coverage determination, but what we'll do is if we see that there should have been one in the grievance case, we will ask the sponsor to pull that up in their system, and we will actually walk through the coverage determination just like we did the grievance. And we also look at the resolution date and time, and we read through the letter to the beneficiary to make sure that it addressed all the issues and that it was clear and that the beneficiary would know that their grievance or their issue was resolved appropriately. Again, I don't have a screen for this mock grievance case, but I will read it to you, and this is an actual case that came into us. It was a written complaint from a beneficiary, and they said, "I have a complaint about my mail order program. It takes so long to get my medications. They want me to call when I'm halfway through my 15-day supply of topiramate. They didn't tell me that they didn't send me a full prescription from the start. I spoke to a supervisor who said that they will overnight the medication to me, but I shouldn't have to call every time I run out of medication. This is really bad customer service." So the sponsor, what they did is that they called the beneficiary a week later to resolve the grievance. A week later. beneficiary was out of meds. Followed up with a written resolution letter, but the staff sending the letter just happened to be brand new and didn't know that they needed to include the QIO rights with that letter. Additionally, this new staff didn't have anybody mentoring them, so they tried as best they could to write the letter, but didn't know what to say. So the letter simply said, "We are sorry about your experience with the mail order program." Conditions that we would most definitely find in this grievance case consist of sponsor failed to notify the beneficiary of the resolution of the grievance as expeditiously as the enrollee's case required, right? The beneficiary is out of medication. CMS expects sponsors to be a little bit quicker than taking 7 business days to reach out to the beneficiary. Access issues are key for us. Other conditions that we would find in the grievance review, sponsors' quality of care grievance resolution letter failed to adequately provide the written notice of the right to file with the QIO, and they did not include the contact information for the QIO. And lastly, the sponsor did not take appropriate action, including addressing all of the issues that were in that grievance case from the beneficiary. Now I'm going to turn it over to my coworker, Jessica, who's going to walk us through ODAG.
Thank you, Doreen. Today I'm going to be presenting 2 examples for Part C Organization Determinations, Appeals, and Grievances. The first example will be in clinical decision making, and the second will be in grievances. But let's start with the basics. During the Part C clinical decision making review, auditors will ask the sponsor to walk through the beneficiary's name and to pull up the initial request. We will also look at the date of the request based on either the facts for a written request, looking at the date and time stamp and confirming that against your universe. And if it's an oral request, we will look to your call notes to see when the request came in. We will also be interested in the type of request. Was it standard or expedited? And how was it processed? Under which time frame? We will also determine if it's a claim or if it is a service request. And finally, we will look to see whether the request stemmed from an appeal or a denial that was upheld. After analyzing the receipt of the request, the sponsor will have an opportunity to walk CMS through its review process using case notes that were documented real time. CMS will want to see all notices, letters, call logs, or other documentation showing when the plan requested additional information from the provider, including the date and time stamp of that request. Also of interest will be any supplemental information submitted by the provider. CMS will then ask for the name and title of the final reviewer, as well as for the denial rationale. We will need to see when the denial was actually made and when the denial notification was provided to the member or the provider. If applicable, CMS will also request to see proof of the appointment of representative form if the request came from someone other than the member. For a case to receive a score of pass, there must be favorable responses to the following questions. Was the notification timely and provided to both the enrollee and the provider? Was the correct notice used? Was the denial language understandable? And did the plan appropriately consider all clinical information and fully comply with CMS coverage requirements? Next slide, please. You will notice that the next slide is very familiar as to what you already heard in formulary and CDAG, so I won't read it to you again, but just please note that each team is concerned about transparency. So again, we'll let you know the disposition of each case real time or come back for any pending cases. Next slide, please. So now we're going to dive into a concrete example of what we might see during Part C clinical decision making. And let's pretend that a sponsor received a claim for evaluation, testing, and programming adjustment of a pacemaker. With the claim, the provider submitted a physician's analysis, review, and report, and CMS would look to confirm the date of service and the date of the request and determine whether the provider was contracted or non-contracted provider. For sake of this example, the claim was submitted timely by a non-contracted provider, and in reviewing the case, CMS sees that the provider remittance advice that services were denied nearly 1 month later because the benefit requires authorization. It was noted that the appeal rights for the provider were not in accordance with Chapter 13, 40.2.3, and the member never received a copy of the denial. So given the circumstances that I just read, how would the sponsor fare in the review of this case? This case would fail for 2 separate conditions. The provider was notified of the denial timely, but the member was not. Therefore, the sponsor would be cited for failing to provide a written denial letter for a standard or expedited organization determination request. The sponsor would also be cited because a remittance, advice, or notice did not provide a description of the appeals process. We will now walk through a Part C grievance review. And in general, a grievance review starts with CMS asking the sponsor to pull up the sampled complaint. We will want to know how the request came in, and we will want to know what the issue was. CMS will walk through all documents cited in Attachment 7B of your start notice and evaluate the complaint against the established compliance criteria. Specifically, we will review all notices, letters, and call logs or supporting documentation showing when the plan acknowledged receipt of the grievance to the enrollee and or requested additional information. If applicable, CMS will also ask to review any supplemental information submitted by the enrollee or his or her representative. To fully understand the issue, CMS will read through the complaint to determine whether the grievance includes an expedited request, a quality of care concern, or a request for an organization determination. After we understand the issue, CMS will request the sponsor walk through documentation showing the steps that it took to resolve the issue and a description of the final resolution. We will also want to see the resolution notification to the enrollee and or their representative. We will want to know if the notification of the disposition was timely. Did the grievance resolution address all issues? Did it appropriately address the nature of the complaint? And if an appeal or organization determination request was included with the grievance, was it addressed separately? So now we'll get into a concrete example for Part C grievances. In this example, the sponsor received a verbal quality of care grievance. The member stated he had colon surgery and complained that while in the hospital, the nurses failed to keep his surgical site clean, and as a result, he suffered complications. He also stated that the quality of the care at the hospital was lacking. Next slide, please. CMS reviewed the customer service representative notes, which reflect that the representative tried to reassure the member that hernia surgeries are fairly minor and common, and closed the case. Being that the case was closed on the same day it was received, you could say that the enrollee was notified of the disposition timely. However, the resolution did not address all of the concerns in the grievance, especially the quality of care concerns. My apologies. Is this better? Thank you. Okay, so to summarize this case, the sponsor would be cited for the 2 conditions identified on the screen. First, the sponsor did not take appropriate action, including a full investigation, or appropriately addressing all issues raised in the grievance. In the example that I just gave, the representative only spoke to the upcoming surgery and did not respond to the alleged quality of care concerns. Second, the sponsor did not respond to the quality of care grievance in writing as required. If you remember, the case was closed by the representative at the conclusion of the call. Since the sponsor verbally closed the case, it also failed to provide the beneficiary with written notice of their right to file with and the contact information for the QIO. This concludes the ODAG portion of today's mock audit, and I will now hand the presentation back to Tawanda to review SNP model of care.
Next slide. Special Needs Plan Model of Care, which is affectionately known as SNP MOC. So, although I'm not a nurse, I will play one at this conference. So let's walk through the first case. I will discuss just one case in the enrollment verification review and also discuss one case in the health risk assessment, interdisciplinary care team, and individualized care plan review. Next slide, please. So for all areas in SNP MOC, The samples are provided the Wednesday before. Unlike the formulary CDAG and ODAG, we received feedback from the sponsor, which indicated to us that it's just too much documentation to prepare the day of the audit. So we, in fact, provide them the samples the Wednesday before we actually start the audit. And just like formulary CDAG and ODAG, we want to be transparent about all of the audit areas in declaring pass and fail. And if we come to a case that we need pending, we will circle back and declare pass and fail either during the pre-exit or the final exit conference. Next slide, please. So during one of our audits, we received an enrollment verification case as follows. So as we walk through this case, we verify the beneficiary name in the sponsor system, match our sample list. Secondly, the enrollment receipt date for this particular case was stamped February 28th, 2008. Next, the beneficiary's eligibility date for Medicare indicated June 2004, as well as Medicaid was eligible for June 2004. So they were, in fact, properly enrolled. And next, the beneficiary was enrolled March 2008. So they met the eligibility and they were properly enrolled timely. Next, the beneficiary's eligibility reevaluated. When asked the sponsor to provide documentation showing continuing eligibility, the sponsor was unable to provide it. The sponsor stated that they had an influx of enrollment and competing priorities and was unable to reevaluate the beneficiary's SNP eligibility. Next slide. Because this was a systemic issue, the sponsor received the following condition, and it is the sponsor did not re-verify the beneficiary's dual eligibility in a timely manner. So next case. So this would be the SNP MOC, HRA, ICT, ICP review. And the order of review is as follows. We indeed verify the beneficiary's name. We check that against what they show us in their system with our sample list. Then the beneficiary enrollment date indicated March 1st, 2008. The sponsor did indeed complete the initial health risk assessment, but that was done on June 11th, 2008, which is a little bit over the 90-day requirement. The sponsor also completed an individualized care plan, ICP. However, the plan did not include outcome measures. Next slide. So when the audit team asked why the HRA was not completed within 90 days, the sponsor indicated that they were unaware of that requirement. Since this is a systemic issue, the condition as follows is the sponsor administered the initial health risk assessment to a beneficiary more than 90 days after their enrollment. Also, the sponsor was unaware that the ICP should include measurable outcomes. Therefore, the sponsor received the following condition. The sponsor did not include measurable outcomes to the individualized care plan. So with that, we will move to the compliance program effectiveness review. Daryl?
All right, good morning, everyone. Again, my name is Daryl Brookins, and I'll be speaking on the compliance program effectiveness review of the audit. And I hope everyone can hear me. I am a minister also, so I'll try to use my preaching voice, but don't worry, I won't get too carried away. So, compliance. We also have a compliance team, and I just want to start off by saying that actually, as it's already been noted, the span of the audit covers 2 weeks, but with regards to the compliance team, their activities actually start long before week 1 of the audit. As soon as the universe is received, our compliance team goes into action. One of the first things they do is they actually look at the compliance universe and they validate it just to ensure that we actually received what we requested. Okay? Secondly, there is a self-assessment questionnaire that each sponsor will receive, and they also submit this with their universe. I just want to mention that the compliance team relies heavily on this SAQ, so I just want to stress that you fill it out as completely and accurately as you can, because this is a document that is used heavily throughout the audit with regards to the compliance team. Okay, next slide. So again, some of the pre-audit activities that the compliance team does. One of the major things they do is once they receive the universe, they verified it for accuracy and completeness. The first thing they will do is pull samples, which they will submit to the sponsor. And these samples are, this sample request is submitted the Thursday before the start of the audit that following Monday. And these samples requests include certain things. There's a list of personnel that the compliance team will interview when they come on site during week 2, compliance program policies and procedures from the sponsor, HPMS memos that the sponsor has received. And one interest that we have here is because when CMS issues HPS memos, we will be looking into whether the sponsor received them. If there were any instructions in the memo that the sponsor should comply with, we'll be looking to see that you are complying with instructions in the HPMS memo. We also are interested in any disciplinary actions that the sponsor may have taken for whatever reason. Next slide, please. Okay. Also, monitoring and auditing activities, as well as information on your FDRs. We do look at FDR oversight quite heavily as part of the compliance audit, so we want to ensure that we receive information on this, as well as any incidents of non-compliance and any issues with regards to fraud, waste, and abuse. Next slide. All right, so again, once we receive, determine what samples we wish to submit, we submit that to the sponsor. The documentation, the sample documentation request will be submitted to the sponsor, again, which the sponsor will be submitting that documentation back to the team before the start of the audit. And typically, that documentation is sought from the sponsor the Monday of the start of the audit. Typically, when the entrance conference takes place, which we've mentioned earlier, the compliance team will be looking for that documentation. And also, one of the things we'll do is, as far as those individuals we will be interviewing, we would have finalized the interview schedule prior to coming on site. We do want to make sure we make efficient use of everyone's time, so you will have a detailed schedule of all interviewees that we would like to see when we come on site. Next slide. So now we're into week 1 with the compliance team. During week 1, again, the compliance team is very busy. They've received all documentation that they requested with regards to the sample. So week 1, the compliance team is reviewing that documentation. They're also, as best as they can, they're staying in tune with the other audit areas that are going on during week 1. They will be receiving daily summaries for each of the team leads for those other areas, and CDAG, ODAG, etc. And the compliance team will also be listening in on the webinar sessions during week 1. Just want to mention that week 1 is very busy for the compliance team, because what they're seeking to do is gain as much information as they can from the other audit areas that are going on that week. Next slide. So again, as I just mentioned, the compliance team is gathering intelligence, identifying areas of concern, because what they look to do when the compliance team comes on site during week 1, they wish to have honed in on any specific areas that came up during week 1. So this is a very important thing to keep in mind. When the compliance team comes on week 2, they will be focused. They will already have an idea of what issues the sponsor is having. So that is what they're going to be focusing on. And then there may be other issues that come up while they're on site. Also, if there are any questions that the compliance team has developed from reviewing your documentation prior to coming on site week 2, they will be coming with those questions in hand for the sponsor to seek clarity when they come on site during week 2. Again, as I've mentioned, one of the important activities the compliance team goes through during week 2 is conducting interviews. Again, the sponsor would have received, prior to week 2, a list of all individuals that the team wishes to interview. And some of the key persons that the compliance team will seek to speak with during week 2 includes the CEO and senior leader Medicare management. And the purpose of this is the team wants to determine how involved senior management is with the Medicare compliance program at your organization. Special Investigations Unit of Fraud, Waste, and Abuse will seek to have a discussion with that director, again, to learn how the sponsor conducts surveillance, interviews, and any other methods of investigation related to FWA. We also look to speak with the oversight manager of your FDRs, as well as employees and governing body members that is a member of your board. Most importantly, also, we will be interviewing the compliance officer. You can fast forward to the next slide. And I won't read through it, but there are several key points that the team will touch upon when interviewing the compliance officer. We want to get a good idea of the compliance program from their standpoint and how they carry out their activities. Next, the compliance team will seek to go through what we call 2 tracer samples. These are essentially issues that may have come up during week 1 or an issue that the compliance team may have discovered prior to the start of the audit. Next slide. So again, as I've mentioned, there are 2 tracer samples, issues that the compliance team will go through. I just want to make one point that some of these issues may be relatively new to the sponsor, but if that is the case, the compliance team will adjust to make sure they can gain as much information as possible. Next slide. And again, just make mention once again that there is a second tracer sample that is done, and there's several sources that the team may obtain information to determine which issue they wish to trace. Next slide. One of the final other activities that the compliance team will do is conduct an actual facility walkthrough of your area. And as you can see here, just a few key things that the compliance team will be looking for, as well as the time span that they look to for this walkthrough to take. Next slide. And of course, during this interview, one of the things we wish to point out is the compliance team will seek to be as cordial as possible. We don't want to intimidate any personnel. We want them to go about their normal daily activities as usual. Imagine that we're just as invisible and we just want to observe daily activities as your personnel are going through with the operation. And I just real quickly, I don't know if I have time to go through 2, but maybe I just want to touch on at least one sample of a condition that came up from an actual audit. You can fast forward about 2 slides. Okay, right here is fine. Here we have a condition that came up during one of our audits where a sponsor did not provide evidence that general compliance information was communicated to its FDRs. If you see here, this is an actual question from the self-assessment questionnaire that was submitted to the sponsor. Here I have a slide from the actual questionnaire which the sponsor received stating the question, the sponsor's response of yes, that they fulfilled this. They provided documentation and support, and they also provided which department is responsible for seeing that this is carried out. Next slide. So what the team does, they will review the self-assessment questionnaire, take into consideration the sponsor's response, but they will also, in reviewing documentation and in the course of conducting interviews, in this particular case with the compliance officer and the FDR oversight manager, the team assessed and determined that standards of conduct and Ps actually were not provided to the FDR as indicated in the self-assessment questionnaire. So this led to the condition standing as is and will be reported in the audit report. Do I have time to go through the second? Okay. So just a second condition, real quickly. Here we have a condition that came up where the sponsor did not conduct monitoring of its FDRs to ensure that they fulfilled CMS compliance requirements. And again, this is an actual question from the self-assessment questionnaire, question number 73, as you see indicated here. Next slide. So again, just a screenshot from the actual questionnaire, and you'll see question 73 where the sponsor indicated yes, that they fulfilled this, they provided documentation, and they also indicated the department that is responsible for seeing that this is carried out. Next slide. But again, in the course of the compliance team reviewing documentation, in this instance, there was an interview with the FDR oversight manager. Again, the sponsor indicated yes on the questionnaire, but in the course of document review and interviewing the personnel, the compliance team found out that indeed this requirement was not fulfilled. So that would lead to the condition, as stated earlier, still standing. And again, just real quickly to wrap up, in the spirit of transparency, while the compliance team is conducting the audit, they will be making the sponsor aware of any conditions that arise so that the sponsor is fully aware of what's happening. And there are no surprises when the exit conference takes place. So at this time, I'll turn it over to Wanda. Thank you.
Thank you,
Oh,
Daryl.
I'm sorry.
I'm going to just summarize us. So what we tried to do today was give everybody an idea of what to expect during a 2014 audit. And our goal is we hope that you also have the mailbox email address that was attached to an earlier presentation. If you don't, I can give that to you. But we are always open to answering any questions from sponsors and health plans. It's very important to us to make sure that we field the questions in the mailbox timely. So if you're, especially if you're preparing for an audit or something, we know that you tend to have questions, and so we are there to help you with those. We also walked through the different performance areas and what you can expect for each of the areas that we audit. And now what we're going to do is just turn it over to the audience for questions.
Thank you. Jenny O'Brien, United Healthcare. So it'd be interesting to hear from each of you if there was one thing that the organization can, what's the most frustrating thing when you get in there? So we can read everything that's on there, but for your team to be effective, what are some of the in each of the areas, if we only did X, it would make your job easier to get through that?
So I can answer from a CDAG perspective. One of the things that I see is that sponsors don't always oversee their PBM properly. And sometimes if they do things in-house, well, whether they do it in-house or whether they do it, whether they delegate the PBM role, for example, processing coverage determinations or appeals to the PBM, they don't oversee it. They might get reports from the PBM that state how many cases they processed, but they're not looking at the quality of the processing. They're not looking to see if notification was mailed timely to the beneficiary, and they're not looking to see if their PBM, maybe their PBM delegates to a mail order processing vendor, and they sort of lose sight of when that notice actually gets sent out. So that's probably one of the key things for CDAG that I see in that review.
I can go next. So for SNP MOC, one of the things that come to my mind is sponsors, during the audit, sponsors are unable to show documentation that they've reached out to beneficiaries. In other words, when they need to complete their health risk assessment and individualized care plan, sometimes beneficiaries are non-responsive. And that's okay. But we just need sponsors to be able to document, to show CMS that you have indeed made these attempts.
For formulary, I would say I'd like to echo what Doreen said. We see a lot of issues where the plan doesn't have proper oversight of the PBM. The other thing I'd like to say is with the impact analyses that we sometimes request when there's a possible ICAR or finding, sometimes there isn't proper quality assurance of those impact analyses, and they can be not always completely accurate or reflective of what we've seen during the review.
And for ODAG, I'd say that the one thing that we see is denial reasons on the EOBs that may be unclear. We see abbreviations that aren't defined or codes that a member may not understand. We've seen a lot of improvement, but there are still cases that, the language is there, it's just not understandable.
Yeah, and also speaking from the compliance standpoint, as a compliance team lead, I'll just echo what both Sheetal and Doreen stated as far as FDR oversight. In addition to not just the PBM, of course, your PBM, I would certainly expect oversight of your PBM, but that seems to be a common theme that seems to surface within the compliance program with regards to FDR oversight. Another thing that I will see, as I stated earlier, the compliance team is looking into what's going on during week one, and we're paying attention to issues that are coming up during the first week of the audit and the other program areas. So when we come on during week two, if we're not seeing those issues bubble up in your compliance area, I'm going to be curious as to why they're not surfacing. Because the way I look at it, if there are issues in any of your other areas, your compliance program should be capturing it, and I should be seeing it. So if I know of specific issues in ODAG and CDAG and formulary, when I come on site for compliance, if I don't see them bubbling up in your compliance program, I'm going to be curious why.
And I just want to add one other thing, and I'm going to be looking to Jerry to see if he say cut, 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 cut. So I want to go back to the PBM oversight. And one of the things that's frustrating for us is we feel bad for sponsors. It seems like they're at the mercy of their PBM, and sometimes we struggle with that because ultimately CMS has the contract with the sponsor, and the PBM works for the sponsor, so we don't get that dynamic. But what we want to just continue to echo the fact that the oversight of the PBM is so essential to be successful in this program. Any reports that you think that's necessary for the PBM, from the PBM, to make sure that beneficiaries are receiving the appropriate care, their drugs, we encourage that. What you will find is during one of the sessions that's coming up, one of the sponsors will talk a little bit about they actually had access to the PBM systems. They will run their own report. They will also task the PBM to run reports for them, but they will also go into the sponsor's system and run their own report. And hopefully one of the things they will share is the one minor issue that came up on their audit was the fact that they didn't realize they had access to that, because had they realized they had access to it, there's no doubt in my mind that they would have been able to go in and oversee and run their reports. So those are the things that we want to share. And I want to say thank you so much for giving us that question and giving us an opportunity to expand on some of the things that we get frustrated with doing the audits. So are there any other questions?
Hi, thank you. I find this very informational. Question is, for plans that self-disclose compliance issues to CMS, whether it's through their account manager or any other avenue through central office, how does that weigh into when you do an actual audit and we're in remediation, or it's something that we're working on when you can complete your reviews?
That's a good question. I'll take that one. So during the audit, one of the things, when we sent out the start notice, we also sent out a self-disclosure template. We asked the sponsor to please self-disclose any issues that you have. So when we take a look at it during the audit, we look at several things. One, we look at, was the account manager aware of this, or are you working with central office with this issue? The other thing is, we want to see that the issue is corrected. And if the issue is corrected, we need to verify that indeed the issue is corrected. If it meets all of those criteria, then it will be an observation. However, if you reported it to the account manager and you're still working through the corrections, then indeed that will probably still be a CAR or ICAR, depending on how significant the issue is. Does that help? Great. And I know one of the things that sponsors struggle with is, should I self-disclose? Should I not? And will this result in a notice of noncompliance or a CMP or any other issues? But from the audit standpoint, it is of help to you if you self-disclose the issue and correct, and we verify that it is indeed corrected. So I hope that helps. Are there any other questions? Okay. Well, we thank you so much for your time. Enjoy the rest of the conference.
Okay, we will be taking a 60-minute lunch break, which means that we will return here at 1:15. For those of you who are in-house with us, there is a cafeteria downstairs, and for those of you who pre-ordered your lunch, you can pick it up at the Jazzy Man Cafe, which is just outside the cafeteria downstairs. Thank you so much, and we'll see you back at 1:15.